So how do you test for Lyme disease? The critical part is that the antibody test should not be used exclusively to make a diagnosis of Lyme disease, because not everybody makes an antibody to Borrelia, the Lyme bacteria, and the antibody test does not pick up all the strains of Borrelia, the Lyme bacteria that are circulating in the European Union and indeed throughout the world. There is no gold standard test available. With COVID, we have a PCR, but even the PCR is not 100%. And studies have shown that even with COVID, after the infection, the antibody test may only last for a couple of months. Therefore, you can be 3 months after your COVID infection, never get a COVID antigen test or a PCR test, and here you are 3 months later still sick. You had a COVID illness in the middle of a COVID pandemic. You didn't have a PCR. The antibody test is negative. Do you have COVID? Of course you have COVID. Your persistent symptoms are consistent with that condition. So you have to use clinical history and clinical observation to make the diagnosis. In the future, there may be a PCR test available, there may be culture available, but at the present time, culture is only a research tool, and indeed in the laboratory, there are research laboratories that can culture Borrelia. However, Borrelia circulates in the bloodstream in very, very small numbers. If you get a blood culture positive for a bacteria like Staph aureus, there's hundreds of thousands of copies. Even in the setting of acute seroconversion with Borrelia, there's only 10, 20 copies. And then following the acute seroconversion, there's less than 1 or 2 copies, or even 0 copies in the blood. The Borrelia has gone into the tissues of the body. So if you do a blood test in PCR, it will not necessarily detect Borrelia. But either way, these tests are not available in most laboratories throughout the world. It's a difficult bacteria to culture. Some people have proposed biomarkers, indirect measures, inflammatory markers, other proteins that might suggest Borrelia. However, going back again, an antibody test can be helpful, but it is not the most important way to diagnose Lyme as a clinical diagnosis. Now, classically in medical school, you learn that there's different types of antibody. There's IgM and there's IgG. We've learned this for infections when we went to medical school, for toxoplasmosis, for CMV. The same applies for syphilis. But we do not have a good understanding of the sequence of antibody evolution with Lyme disease. Even with syphilis, I have patients who are IgM, which is only supposed to last for 6 months, persisting for 2 years following infection. With COVID, we're learning that many patients have IgG positive. They never develop an IgM. So you're supposed to get an IgM first, within the first few weeks, possibly a few months. You're supposed to develop an IgG antibody after that, but the sequence of events with antibody tests are poorly described and poorly understood. I've seen patients who never developed an antibody. I've seen patients who developed an antibody not until 6 months following infection. I've seen people who developed a positive antibody at 6 months, went negative at 12 months, and then went positive again at 18 months. An antibody test is your immunological response to an infection that's either in your system or was in your system. If you have a poor immune system, you may not generate an antibody. I have people who are HIV who are immunocompromised, and they were persistently antibody negative for a period of 6 months following seroconversion. They were actually read as a false positive HIV antibody originally because it was such a low level antibody, but when I did the viral load, they were actually HIV positive. How did I know to pursue the diagnosis of HIV? Because they had a high-risk HIV exposure in Kenya. Their symptoms were consistent with HIV. So I think Lyme disease is no different. Based on your history, based on your clinical suspicion, it's appropriate to develop an antibody test, but you have to be able to interpret that test. I have people who are told they have a false positive test. Another interpretation would be a weakly positive test. I have people who have a strongly positive test, and they're told by doctors in the middle of having severe symptoms without any treatment that this is an old antibody, not a new antibody. You can't tell from looking at an antibody, IgM, IgG actually, how long that test has been in their system. So there are no good serological tests to make the diagnosis. Now, we have a system of having two-tier Lyme serology testing, ELISA, C6 peptide, immunoblots, all of these tests, but none of them are perfect. Some of these tests can cross-react with other proteins from Epstein-Barr virus, from rheumatoid arthritis, periodontal disease, autoimmune diseases. So some people say it could be a false positive, but in reality, if it's compelling that they've had a Lyme exposure and they've had symptoms consistent with Lyme, an equally tenable hypothesis, it's not a false positive, it could be a weak positive. Some people talk about false negatives, and I've mentioned this before. If you're in the window period, you can have a negative test, but there's actually Borrelia circulating in your bloodstream. I've seen patients who had persistently negative tests. I have patients who are immunocompromised who never develop an antibody response. And then sometimes the antibody test can fluctuate. It can be positive, it can go negative, it can go positive and negative. And then sometimes when people receive a short course of antibiotics early in the course of their Lyme disease, the antibody test never goes positive, but the antibiotics do not eradicate the infection. So you can have seronegative Lyme disease. And some studies, they've actually been able to stick needles into the knees of patients with Lyme arthritis who had negative tests despite having a clinical suspicion of Lyme disease. In research studies, they've been able to isolate Borrelia from the synovial fluid of the knee of the Lyme-infected patients. So I think it's very important to understand the concept of when to use an antibody. When would I use an antibody? If I have somebody that came in who pulled a tick off themselves and came in weeks or even months later with symptoms of Lyme disease, I treat. If you had somebody who came in who didn't have much in the way of symptoms but had a tick and had a rash, I treat because you should be able to put together a tick infection, a rash consistent with Lyme disease. If the rash of Lyme disease in the skin, there's active replicating Borrelia bacteria in the skin, and they are in the process of disseminating into the bloodstream, going to all the tissues of the body. So that's a situation that you would want to treat. If you've got somebody who's months and months down the way and they're sick very often, it's worth doing the Lyme antibody test. But like I said, the test is not 100% positive. But the current gold standard for testing in the laboratory is the antibody test. But many studies will show its sensitivity is between 30 and 70%. And if I have Lyme disease, I want the test that is 100%, not 30%. The additional issue then is there's other infections besides Borrelia. In Ireland, the vets at UCD have done studies. They've picked the ticks off the animals in rural communities, and they've then been able to ground up the ticks from the animals. And the ticks in Ireland are carrying 3 bacteria. They're carrying Anaplasma rickettsia, they're carrying Babesia, and they're carrying Borrelia, the Lyme bacteria. So there's 3 different tick-borne infections, bacteria, that the animals are carrying in Ireland. Similar studies need to be done in the rest of the European Union and indeed the UK. There's now been cases of tick-borne encephalitis isolated from ticks in the New Forest, and a visitor who was infected with tick-borne encephalitis. Tick-borne encephalitis is classically found in Eastern Europe and over 500 to 1,000 cases every year in Sweden. So ticks carry lots of things. Studies in southern France have shown the ticks to carry 15 plus different bacteria and indeed some viruses similar to tick-borne encephalitis. So you have to understand that ticks carry lots of bacteria. If you suspect a tick-borne infection, you should make a clinical diagnosis and not depend exclusively on antibody tests, because antibody tests are not 100% accurate. There's false positives, there's false negatives, and if you test only for Borrelia, it might not be Borrelia. It might be another infection caused spread by a tick bite to humans.